Assalamualaikum. Good day to fellow surgeon and colleague. I am Muhammad Nazri bin Ahmad Yunanis, Medical Officer from Hospital Encik Besar Haji Kasum, Keluang, currently working at Orthopedic Department. Today I would like to express my gratitude for the opportunity given to present a case done by our team. Hand is an extremely complex organ. The design, tendon excursion, pulley system, sensation, all together works in harmony to facilitate daily activities. Carrying common tasks as simple as pushing a button looks simple yet involves sophisticated process. A single rigid finger may disturb hand function and therefore affecting professional future of the patient. Treating this condition involves comprehensive process, as operation is just one of the few stages of treatment. Having said that, the surgical intervention itself remains a challenge. Due to hand complexities, post-operative results are often disappointing, as mentioned by Jimenez et al. I would like to share a case done by our team in the hospital Encik Besar Haji Kalsom, a case of proximal interphalangeal joint stiffness treated with percutaneous dorsal needle capsulotomy. This is a case of 17-year-old teenagers presented to our clinic with complaint of pain over the left ring finger following trauma. He was treated conservatively for closed fracture, head of proximal phalanx of left ring finger with acceptable X-ray. Unfortunately, he defaulted follow-up and came to us 2 months later with stiffness of the left ring finger. The finger was stiff, so much so that it was limited with active and passive range of motion of 0 to 30 degree flexion at the level of proximal interphalangeal joint. The range of motion of metacarpophalangeal joint and distal interphalangeal joint of left ring finger were otherwise full. So what did we offer to this patient? He underwent percutaneous needle dorsal capsulotomy of proximal interphalangeal joint of left ring finger, and his finger turned from this to this. Intraoperatively, we were able to achieve 0 to 90 degree of passive flexion over the level of proximal interphalangeal joint. It was then immobilized with dorsal blocking splint for a week of duration, and physiotherapy was initiated later with good functional outcome. For surgical release of proximal interphalangeal joint, extension contracture was done through open surgical release, as described by Young et al. Curvilinear insertion of a dorsal aspect of finger done, followed by dorsal capsulotomy and collateral ligament incision. It was done through direct visualization. Challenges faced in handling such cases is because of the post-operative results that are often disappointing thanks to complex anatomy of hand. The operation itself is indeed technically demanding, requiring proper soft tissue handling and meticulous dissection with intent of achieving good functional outcome. Minimizing pain, bleeding, and edema post-operatively can reduce the process of inflammation. This in turn permits earlier motion and preventing finger from developing stiffness. One way to achieve this is by minimally approach surgical technique. However, there has been very limited literature describing the percutaneous needle capsulotomy of proximal interphalangeal joint. Young et al. Described percutaneous needle capsulotomy for flexion contracture of proximal interphalangeal joint, while a case report by Sabiyit et al. From Hand and Microsurgical Technique, University of Science Malaysia, described percutaneous dorsal capsulotomy for metacarpophalangeal joint. In our case, 18-gauge needle was inserted at 45 degrees to the skin over the ulnar aspect of the left ring finger. Radial or ulnar approach can be used depending on surgeon preference. The needle must be away from lateral band of extensor tendon at level of head of proximal phalanx. The needle was then advanced until it comes into contact with head of proximal phalanx, then retracted about roughly 1 mm. From there, dorsal capsule of proximal interphalangeal joint was incised by swinging the needle volar and dorsally with simultaneous gentle flexion of proximal interphalangeal joint. Be gentle not to force excessively over the proximal interphalangeal joint together with simultaneous gentle incision of the capsule. The gritty sensation while incision will give you the idea that you are at the correct location. The fibrous tissue release with subsequent loosening of PIPJ to flexion position marks the release of dorsal capsule. We believe that early rehab will provide good functional outcome. Achieving this through minimally invasive technique provide early rehab as it permits lesser extent of soft tissue injury inflicted by open approach. With minimal soft tissue damage, lesser bleeding, lesser pain and edema provides favorable outcome and subsequently allowing early range of motion. Having said that, this approach is not always a substitute to open surgical release, but it can at least be attempted once before more extensive surgery was offered. This is a simple procedure, but research need to be conducted to study the effectiveness of this technique. With that, I end my presentation. Thank you.